with Dr. Shamlan Murge. Today, we are very honored to have Dr. Asthma Al-Rashid as the speaker for this keynote session, Women in Surgery. Now, allow me to introduce today's speaker. Dr. Asthma Al-Rashid is a fellow of Royal College of Surgeons of Canada and a fellow of the American College of Surgeons. She has received her training in general surgery at McGill University in Montreal, and she's both certified in general surgery. She has completed critical care fellowship at McGill University and the laparoscopic bariatric and metabolic surgery fellowship in Laval University, Quebec City. She is practicing full-time as a general and a bariatric surgeon in the Department of Surgery and as an intensivist in the Department of Critical Care and Anesthesia in Al Amiri Hospital in Kuwait. And she also works part-time at NeoCare Medical Center as a general and bariatric surgeon. Dr. Al-Rashid is the Assistant Program Director of the Surgical Foundations Program in Kuwait Institute for Medical Specializations since 2017, a clinical tutor and a lecturer for 3 postgraduate programs, the Kuwaiti Boards of Surgery, Critical Care, and the Pharma D. Dr. Al-Rashid is a fierce advocate for empowering women in surgery. She is the founder and the chair of the Women Surgeons Committee in Kuwait Association of Surgeons and has championed the historical documentation and led many activities in tackling gender equity in surgery in the Gulf and the Middle East, among many other accomplishments. Additionally, she is a co-founder of the Women Surgeons of Kuwait Research Network that has encouraged and created research opportunities for many surgeons, physicians, and students. Before we begin, if anyone has any questions to the speakers, please type in the chat box and it will be addressed during the Q&A session at the end of the webinar. Also, this webinar is being recorded and streamed live on our GSN YouTube page. Let's dive into the session. Over to you, Doctor.
Thank you so much for the kind introduction. I'm so happy and pleased to be here today with all of you. This is an amazing conference, and it's like really make me happy to be a part of encouraging the next generation into moving this field forward. So today I'll be talking to you about women in surgery. As we start this talk, I really want to say that if this is working here. Can you see my slides? Yeah? All right. Yes. So, okay, thank you so much. All right, so I have no conflict of interest, except that I'm a woman who is presenting this talk. And I want to share with you this photo of this amazing ballerina who, her name is Chandra Kikanville, and she started to learn how to dance at the age of 5. And once she started to take these lessons, in a few years, she went in by the age of 8 and joined an academy to learn how to professionally become a ballerina dancer. Fast forward, in about 9 years or so, she became a professional ballerina, and she chose that career. And during her training, she as well traveled to Germany, where she went and refined her style there, and came back to Colorado and worked in the company where she's working on for about 31 years before take her final bow and retire from the professional dancing, but move on to another line, which is training the next generation. She managed to marry and have 2 children throughout her journey. The reason I'm sharing this photo with you, if we can see how that profession is so hard, takes a lot of skills to master, to be able to execute something so beautiful. When you go and see the show, you'll be dazzled for that such amazing performance is being conducted. And meanwhile, what we see is the final product of what the ballerina dancers would train and try, and we don't see this part. We don't see the part where there is the hurt, where's the pain, where's the agony, where's the physical, emotional and even mental stress that they would go through. And the reason I'm sharing this with you is also often to us in surgery, and as maybe medical students, or being just finishing medical school and being interested in surgery and thinking about joining such profession, we often see the glamorous and the great part of surgery. And less often we share the failures, the stress, the long hours, everything else that is the tests, the exams, the studying, and everything else in between. And therefore, it was important for me to talk today, especially being a woman in this field, where there's a lot of other standards that are women held for. It's important that we see the whole picture. We need to have a panoramic view about our profession and where the women stand in that profession. So, because at the end, it's quite really important that we don't want you, as you choose to become a surgeon, to be feeling that way, but rather to have a meaningful and a fulfilled life and career. So let's take a step backward and talk a little bit about women in the history of surgery. And I'm not going to talk a lot about this because that can be a topic by itself, but it's important to understand that women, as far as in ancient history, have participated in medicine and in surgery. And so as far as 3,500 BC, there are there's evidence that like in Egypt history, in ancient Greek, and as well as in China, of women being the part, an essential part of medicine, as well as surgeons. And then if we move more to the Middle Ages, the Victorian era, and even in the early and late 20th century, there's a lot of changes that happened that affected women in some areas where they regarded to be the healers. And then there are times where they were like hunted and they were banned from practicing medicine and surgery. So it's important to understand that you as a woman have been in that field for a quite long time. And it's all the climate change when it comes to politics, religion, and so forth, and so many other aspects that changed how women were placed and changed their status when it comes to medicine and surgery. This is it's. And I shared with you a couple of references down there that you can actually take a look and have more information about the history of women in surgery. So if we are to move forward in time and look at the current status of women in surgery today in the millennium, and you look at the numbers of women, for example, in USA, in the UK, and quite globally, we see a transition from women being in medical school as the most graduating compared to the representation in the workforce. So for example, in the US, only about 20 in 2000 by 2016, there's only 20 female chairs of departments of surgery. When you look at professors, only 8%. But in totality, the American surgeons who are women, they represent about 19% of the surgeons' population. If you look at the UK, for example, so similarly, there's underrepresentation when it comes to full professorship and chairs of department, and there's a variability when it comes to representation in subspecialties, the highest being 25% of women who are pediatric surgeons, where they are like less than 20% in other subspecialties. But if you look in the totality, you would it's about 11% of females who are surgeons in the UK. And with that, the speculation is that it will take another about 100 years or so to be able to get women to represent about 50% of those who are in full professorship. So that's a long way to go. And there are reasons for that. If we take a closer look to here for the Middle East, or particularly in the Gulf countries, you would see as similarly When you look at medical school, majority of graduates are females. However, if you go throughout surgical training and then faculty and so forth, you would see less representation of women. So the question that we will hold in mind, why would women graduate medical school and not pursue surgery? If we look at more countries in Asia, for example, Japan, 7.2% of women in Japan Surgical Society in 2014. Australia, about 12% of their surgeons are women. In Africa, some of the countries as low as 9%, but with more support recently from international professional societies, that number has started to increase up to 14%. So what we learned from this is that until now, women in surgery are a minority. So we have to take a step back and a pause and ask ourselves why women remain a minority in surgery. They are presenting almost 50% of the workforce around the world. So why they would remain to be a minority? So first of all, medicine in general is a long ride, right? So there are so many years that you will spend in the undergrad medical school, and then you're going to go to your internship, and whether you do a medical or surgical specialty, it's quite a long ride. There's so many years ahead of you, and then the thinking is that how I'm going to spend all these years. So from finishing your medical school until graduating and become a professor, it might take between 14 and to 22 years. So to take a closer look to understand and find what are the barriers for women in surgery, there are different barriers if you look at the literature. So there are things that is related to you yourself, and there are things that probably imposed from the environment or from the system where you work. So and we can take one at a time. I think somebody needs to mute themselves. We need to we'll break them one at a time, and then we'll take it from there. So if we look at the internal challenges that a woman can face, self-doubt is usually a good thing to have, because it will going to keep you in check and make you think about things. But when it exceeded that, then you could be suffering from imposter syndrome. And there's a lot of papers in the literature that shows that imposter syndrome is higher in women than men. So this could be something that holds you back, thinking that maybe I'm not good enough. The other important thing that we have to talk about is that during residency or training, it's important to think about that. That's the age where women would consider, conceiving or building their families. So childbearing and family planning can be an issue for a woman who is thinking or entertaining the idea of joining surgical surgery. So this paper from United States, and what they found is that women in surgery has about 1.4 biological children less than the national average, and the age of pregnancy would be almost 10 years after the general population. Now, these figures may be different from different parts of the world, but this is what we have so far in the literature. So these are considerations that may hold women when it comes to selecting a surgical specialty. And as I promised you, I want to show you the whole panoramic view. So when you decide and think this field is for me, you are doing it where you're informed about what's out there. Now, a recent paper a few months ago came in that looked at, in the JAMA, that looked at incidence of infertility and pregnancy and pregnancy complication in US female surgeons. That national survey covered about 850 women surgeons in America. And what they found is that female surgeons are more likely to delay pregnancy due to their training. They might use assisted reproductive treatment and experience pregnancy complications. And they also found that women who operate more than 12 hours while they are pregnant, they are at a higher risk of complications from pregnancy. So the meaning of this is that we really need to understand those risks and what are the things that we can change in culture and in policies to hopefully reduce that. Another important issue is personal relationship. So there are, and this is also data from the States. So it's important to understand that up to 33% of surgeons have reported that they've been divorced, and a majority of those surgeons had multiple conflicts with their spouses when it comes to life and work integration or issues related to depression and burnout. So these are serious things, and it's important that we look at these things when we decide what are the things that we want for ourselves. Now, it's important as well. This is another paper that came out in Jackson. It looked at dual physician relationship. So not only physicians being in a relationship or having domestic partners, but also looking at physicians or surgeons marrying from each other. So about almost close to 8,000 responding surgeons, and 90% had domestic partners. And then what they found is that surgeons who are in a relationship or married with another physicians, they have experienced greater challenges balancing the personal and professional life and career. Another consideration, as I said, the importance of work and life integration, and I like that term better than the work-life balance, because work and life balance always give the sense that these are like forces and you have to choose between them. The reality is that you do not have to choose. It's how you integrate, how you prioritize, and what are the roles that you would take. Other external challenges, moving from the personal or internal challenges, are the external challenges such as bullying, discrimination that is based on gender or based on sexual orientation, and so forth. And there's a lot of out there in the literature that look at these, but also for all other surgeons as well. American College of Surgeons has released a toolkit that will help with dealing with harassment and bullying and discrimination. You could take a look at that and learn more about it. A recent paper just was out 10 days ago that actually looked at differences in referring to patients. So if you're thinking about pursuing a career in surgery, these are the things that you have to think about as a woman when you go out there for practice. You are likely to have people refer less to you. So the sectional study in the state, and they looked at about 40 million referrals, and then they found that female surgeons get more non-operative referrals, and male physicians tend to have more biases toward the same-sex referral, disadvantaging women surgeons. So these are the things that we need to address. We need to have science that backs it up so we understand how we can overcome it. Now, this is a paper that looks at perspective from the student's point of view, so maybe closer to the audience here today. So a cross-sectional survey that looked at almost 639 medical students from about 75 countries. And then they found what are the things that would, or what are the factors that would encourage or increase the likelihood of a student pursuing a surgical career compared to those that decreased that interest, that the perceived access to postgraduate training, increased the lengthy study, obviously, and then the perceived heavy workload in surgery. Things that have encouraged students to, or factors that encourage students to want to pursue a surgical career were mentorship, acute element of the surgical specialty, academic competitiveness, as well as being from a higher or upper middle income country. So so it's important to understand all these factors and how can we overcome them. So some other factors that I did not maybe elaborate on, but something that you have to think about is that a perceived perspective of society toward women in that field, the social responsibility, the tradition, the cultures. We touched already on mentorship, but also the perspective from the medical profession as well. So other physicians or surgeons looking at women in surgery. So how can we overcome that? So there are a lot of things that we can do, and we will touch upon that as well as we move forward with this presentation. But it's important to understand that global movement such as I Look Like a Surgeon and other global movements that supports gender equity, not only in surgery, but in medicine and other fields, hopefully push these things forward and improve or reduce the barriers and the challenges for women. So the role of professional societies, changing legislations, looking at the systems, building more mentorship programs, and have an equal pay, because this is an issue for, I'm not sure if everybody knows here, but there are countries, and many countries actually, who would pay women less than men for the same work that they would do in surgery. So it's very important to think, how can we reduce or improve the status for the woman in surgery? And what I'd like to share with you is that it's very important to engage in your community. Whether you are a student during your medical school or you're recently graduating, it's important to look out there and see who are the people around you who have been there, who have done it, who have preceded you. What are the challenges that they have, and how can they help and support each other? So in 2018, when we started the Women Surgeons group in 2019, we were able to have the Women Surgeons Committee in Kuwait Association of Surgeons. Gradually, we started to work together, and then expanded to our neighbors in the Gulf. And we are so proud to see actually the progress and the growth of our community in the Gulf. Now we have the group in Saudi Arabia, in United Arab Emirates. Yesterday, actually, we had the third Women Surgeons of the Gulf meeting, and the first UAE Women Surgeons conference. And it's not only for the women who are into their surgical training, or they have completed their training and they're practicing surgery, but also for the students. So we also encourage students to take the steps and move forward, because this is how we build together and support each other and move forward. So I'll share with you a quick glance at our experience with the woman in surgery. So the idea when that committee was founded is that we wanted to push and highlight the role of women in surgery and support them to be able to fulfill their personal and professional goals. This is our website, and we have a lot of activities. I'm just going to touch the surface here. So we had clear goals, which we wanted to increase the presence and the contribution of women. Wellness is extremely important, and self-development as well, and raising the awareness in our community. So there's a lot of activity that we have done. We use social media heavily to try to disseminate our work, and we work in partnership with a lot of other women's societies internationally, and I already referred to the regional, but also internationally with the Association of the Women Surgeons, and also the Women Surgeons Committee in the American College of Surgeons. And we exchange experiences, we attend conferences, and we do workshops and so forth. One of the important programs that we have done is the Mentorship Program, and it's the first in the region that we have, actually, not only the first in Kuwait that looks at women. That program is 1 year, and people would, resident and women in surgery are encouraged to submit their application, and they are matched with mentors, and then that relationship continues and grows. And this is our third cycle. So as I said, it's a yearly program. You can continue to work with the same mentor or move for another one. And I know maybe the numbers are small to you, but in Kuwait, actually, our numbers we're a very small country, and the surgical community is very small. So these are actually good numbers for that program. Now, the other program that we have is, or the other team that we have is the Women Surgeons Research Network. And research is extremely important because as someone who is in medicine or in surgery, research is one of the tools as a clinician that you have to advance the science. So we established the Women Surgeons Research Network. There are a lot of projects that we have done, completed and published, and there are projects that are also on the go. And we are happy to be one of the pioneers as well to establish that within our community. During the COVID crisis, the women surgeons have done tremendous work, leading and spearheading production of guidelines and conducting workshops and so forth to make sure that the safety of our patient and our clinical work is up to date with the novel coronavirus as well. our women in surgery have worked in research, in ICUs, in so many things during that pandemic, and we collaborated with a lot of other local institutions to move things forward. Now, as I touched earlier about us having our first conference in 2019, followed by the second conference, although it was during the pandemic, it was done virtual, but that's the idea, is just to keep working together and move forward. So we have our friends in Saudi Arabia in 2020, and then we have, as I said yesterday, the third Women Surgeons of the Gulf meeting in United Arab Emirates. The photo down there, if you can see it, that was the photo that was taken in 2019 in our conference, and you can see surgeons, pioneer surgeons actually, because that was a really historical conference where we have pioneer surgeons from the Gulf as well, from the States, who have joined us in that meeting. Now, as I said, we also work with student societies. So last year, we worked with the Association of Women Surgeons, the United Arab Emirates chapter, as well as Lebanon chapter. And during the summer, we have conducted the Young Scalpels Bootcamp, which actually the organizing, most of the organizing team was from different part of the countries, with medical student and juniors doctor helping. And today I'm here with you with the global surgical network, and I'm happy and pleased to be a part of this as well. So as I come toward the end of my talk, what I'd like you to think about is that you're really engaging in your community will help you definitely thrive. So we know now that there are women surgeons or women groups who are in surgery in pretty much all continents. We have in Africa, Asia, the Middle East, Australia, Europe, North America, as well as South America. So what I would suggest to you is that if you're really interested in surgery, find out around you who are the societies, professional societies, and join them. Take a look at their programs, see what they can offer you as a student, and then you will not regret that. Now, it's important to mention as well, it's not only women's societies who would help you as well, but there are other surgical professional societies who have women committees within them. The idea is that we all together work, men and women, because allyship is extremely important. As I mentioned earlier, women are still a minority, so we definitely need the help, the support, and the understanding of our colleagues, men. So coming to an end, what I'd like to remind you and go over with you is that women are an integral part of the workforce, and we continue to grow. Now, there are specific challenges and barriers for women, but it's important that we tackle them throughout the journey, and it's important that we work together to be able to make the surgical field more appealing and more inclusive for all those who are interested. It's obvious that we also need more accurate data, because there's a lot of areas, or there's a lot of countries in the world we do not have the accurate numbers and data of women who are interested in surgery, who are or in the workforce, and that's really important, can change a lot of things for us. And I shared with you at the end our story and our experience in the Women Surgeons of Kuwait, and how it's important to actually start the work and work together. And I hope with that if you choose to be a surgeon, that your journey and your life would be meaningful and fulfilled. Thank you.
Thank you so much, Dr. Asthma Al-Rashid, for the very inspiring talk. And I believe much work remains to make the surgical workplace supportive of women and empowering them to optimally contribute. And I believe these efforts will definitely benefit the community and the future generation of surgeons like us as medical students. And most importantly, it will positively affect the care of patients. And so all of us, we have an important role to promote gender equity. And I believe not just in surgery, and also in our daily life. And thanks again to Dr. Asthma Al-Rashid for such a stimulating and motivating talk. And now we shall move on to the Q&A session. And to all the delegates and participants who are watching us on YouTube Live, if you have any questions, please type it out in the chat box. So we'll wait for them. So Doctor, so far we have no question in the chat box. So I personally have one question that I thought of asking based on doctor's presentation just now. So Doctor, how do you think male doctors, male surgeons can actually make the workplace more supportive of women?
Thank you so much for asking this question. Actually, it's very important. I think one of the most important things is that we need to call things by but what they are. So I think one of the common things that can happen is something called microaggression. I didn't talk about it today, but it's something that is actually very common. And often when it happens, people are not aware that it's happening. So being what we call an ally, for a woman is that if you have witnessed, for example, a microaggression, so you are the what they call a bystander if you just stood there and did not say anything, versus you would be an upstander when you will take a step and make a comment or intervene, again in proportionate to what happened in front of you. The other thing is that it's important if you are in a position where you can offer academic opportunities, research, if you can have like be a mentor. So there's a lot of roles that male surgeons can provide for women surgeons or women interested in surgery to help them move forward. So for example, one of the most common things as well that we get is that for example, would you name I have a conference coming, I have a meeting coming, do you have a name? Often the first name you would have in your mind is somebody that maybe you know, so maybe he's a friend or a colleague. So also we say, one of the things we suggest is that keep a list, for example, for all the speakers, men or women, and the good topics that they can present, the area of their expertise, because also you want to hand them something that they're comfortable and, or like, even if it's challenging, but something that they will add to. So I think there are a lot of things that we can do. Maybe these are some of the things that I have in mind for now.
Thank you for your response, Doctor. I fully agree with that. So far we don't have any question in our YouTube live. So just Doctor, another follow-up question on the question that I've asked just now. Because Doctor have mentioned there are a lot of barriers that women surgeons actually have to overcome. So from your perspective, Doctor, how do you think a male medical student actually can change these barriers that Doctor have mentioned just now?
Okay, so as I said, there are things that if you divide them into the easiest way to look at it is that if there are internal challenges, so this is something then the women have to look after. So you have to see if you have like doubt, if you have imposter syndrome, all these kind of things, maybe you need to talk to somebody about it. The external, as I said, as a medical student, maybe I'm very far along from medical students, but being in medical school, for example, if you have a study group, maybe somebody is not involved, maybe you can invite somebody to be a part of the study group. As I said, if you have a research project and then you think somebody maybe can help you with that, you can offer help with that. And as I said, if you see something when it comes to microaggression that is related to, then again, microaggression can be, it can be based on race, gender, ethnicity, and so forth, then you would be the up standard for that. And then from that part, I think you can help another medical student to be there. And I think having discussions maybe and asking questions with each other and say, even as simple as that, how can I help you? You seem that you have a difficulty in this. How can I support you through that? And then they can also tell you what they need, and accordingly you can act.
Thank you so much, Dr. Asma, on the answer that you have just given. And as a male medical student, I'm 100% support for this agenda. And with those questions being answered, and since we have no question in our YouTube live, so I would like to thank Dr. Asma once again for delivering and clearing all of our doubts. And to all the participants that are watching us live on YouTube, I hope you guys had a great time listening to such a motivating and wonderful talk. And with that, we have come to the end of this webinar. And it's been a pleasure for me to co-moderate this session. And well, to wrap up the session, I believe photo shoot is a must, right? So since our participants can't join us from YouTube, I request all the organizing chairpersons to just on your camera for a brief photo session with Doctor. Yep. Sneha, I think we can go in the count of 1, 2, 3. Okay, maybe we can go for another one. Now we can go for freestyle. Ready, Asma? And go for 1, 2, 3. Okay, fantastic. Okay, thank you, doctor, and thanks to the organizing
Thank you so
chairperson,
much.
Dr.
Thank you for
Udit,
having me
and
today.
thank you, doctor. So,
Thank you.
finally, I would like to end the webinar with a quote that inspired me based on the Dr. Asma's journey as a surgeon. You have to keep going. You never know how strong you are until you look back everything you have overcome. With that, thank you everyone for joining us, and a friendly reminder to the delegates. It's time for you guys to have a cup of tea or coffee, and I hope you guys will enjoy the upcoming talk on innovation in surgery that will begin in 30 minutes time. Thank you and see you guys again. Bye.
Hello, sir. Good evening.
Hi, Sneha. How you doing?
Hi, I'm good, sir. I'm good. How are you?
Good to see you. Good to see you. Okay,
Same
I have a few minutes. I'm going to make a quick cup of coffee.
Yeah.
How long do I have for the lecture, Sneha?
Sir, you have about 1 hour, and it's all right if you want to prolong it also.
Okay, perfect, perfect, great. Yeah, I'm just going to make coffee. We have what, 7 minutes?
Yes, yes, sir.
Thank you so much. All right.
Yeah. Mhm. Hello, sir. Can we begin, if you don't mind?
Sure. Yeah.
Okay, great. So, hello and a very good evening to one and all present here. My name is Neha Yakkali, and I, along with Pooja Shah, will be your moderators for the evening. It gives us great pleasure to welcome all of you to our third and most awaited keynote session as a part of our annual International GSN conference, Revolutionizing Global Surgery. Here we present to you Innovation in Neurosurgery, delivered by none other than Professor Salim Abdul. So for our viewers, here's a little about Sir. So Sir is an eminent neurosurgeon practicing in the United States of America. He is the neurosurgeon in chief at the Abdul Institute of Neurosurgery. He is also the founding chairman at the Department of Neurological Society at St. Louis University School of Medicine, and is also the director of the Center for Cerebral Vascular Surgery and Skull-Based Repair Surgery at St. Louis University Hospital in St. Louis, Missouri. He has served as a visiting professor to over 100 universities across the globe. He has also authored the main reference textbook for brain bypass surgery titled Cerebral Revascularization, in which Sir has detailed extracranial to intracranial bypass surgeries and is considered as the world authority for awake surgeries for brain aneurysms, arteriovenous malformations, and EC-IC bypass surgeries. Sir is also the author of the non-fiction book 3 Invaders. It is an honor and privilege to have Sir amongst us to deliver such an important and insightful session. So, Sir, before we start off with the session, I would please like to call upon Pooja to give out a few instructions for our delegates.
Thank you, Sneha. Good evening, everyone. Good evening, sir. So before we start the session, I would like to instruct the attendees that in case you have any questions, kindly drop it in the comment section. We will address it at the end of the keynote. And once again, we welcome all of you. And sir, I would kindly request you to start us off. Thank you.
Thank you so much. Thank you, Sneha, for that very humbling introduction. Thank you, Pooja. It's great to be with you guys. You guys doing a great job here, and I'm honored to be part of it. I'm going to go ahead and share my screen here, and we'll start right away. So it's great to be with you. And I'm going to give you kind of an overall view of about brain surgery, the way I look at it, and especially I'm going to address the issue of innovation and kind of give you some ideas how you all can contribute to your chosen specialty. So I am calling this talk "How to Become an Innovator," and that is what's important for the next generation, is to contribute to these evolving fields of surgery. So that is what I'm going to stress here. So today I'm going to talk to you about, you've obviously seen a lot of the talks about various surgical specialties. Today I'm going to give you a kind of a little glimpse of the kind of surgery I do, which is intracranial surgery, operating on certain lesions of the brain. And the idea is, when you're thinking about being an innovator, is how do you make things less invasive and less risky for the patient? That is really the ultimate why we are doing all you and I are doing what we do, is to improve patients' lives, outcomes, and to preserve life. So when we talk about innovation here, it's really purely to affect those things. How do we make the quality of life better? How do we prevent complications? How we protect life? So for example, here is a lesion in the brain we call an AVM, or arteriovenous malformation, okay? So the idea is, how do I get here without injuring any brain, go around this AVM and remove it, okay? What kind of things can we do to improve this kind of surgery, okay? The second lesion I'm talking to you about, which I'm going to use as the main example in my lecture today, is a brain aneurysm, which is sitting on this vessel right here. So how do I get there without injuring any brain, come in here in a very safe way and put a titanium clip across the neck of this aneurysm so it's closed off, and the normal vessel is flowing normally inside? Okay. How do we treat a tumor like this in the brainstem? How do we get there safely and remove this tumor without causing any deficit? Or this tumor sitting on a cranial nerve, how do we get here and without injuring anything, remove this tumor so the patient doesn't have any complications? That is a concept of innovation about outcomes and saving life. Okay, so that's those are the kind of examples I'm going to share with you today. So let's talk about aneurysms for a second, and I will, just explain to you some general principles. So essentially, there are four major arteries that supply the brain with blood. The two internal carotid arteries up front, which are right here, and the carotid artery comes in and divides into the anterior cerebral artery and the middle cerebral artery. And of course, they give their branches here. The anterior cerebral artery does the same thing here. Okay. So those are the front arteries. And then you have two vertebral arteries in the back that supply the brain as well. Aneurysms occur at branch points. So essentially, there could be an aneurysm that happened here. There could be an aneurysm happening right here. There could be aneurysm happening here. So here we will call it anterior communicating artery aneurysm. Here we would call it middle cerebral artery aneurysm. So what I talked to you about is how safely do we get there? Well, you can't go through brain, of course, you'll cause major damage. So that would be a no-no. So we have to find natural spaces that would allow us to get here without injuring anything. One such natural space is this right here. We come through here. This is called the sylvian fissure, okay? And we will be coming from here, enter, and then do the clipping of the aneurysm or aneurysms, whatever that is, okay? So that is really kind of the idea of how we get in there. So to do that, of course, we have to do what's called a craniotomy, remove the bone. We have to open the covering of the brain called the dura to get into the sylvian fissure to get here. Okay. Now this part of the brain that has all these major vessels also has below it is the bone where all this sits. This is an area size of a golf ball. And I can tell you, I probably have spent more time of my life in this area than doing anything else. I guess the two things in my life I spend most time in is playing soccer or spending time in this area, okay? So it's a highly specialized area. So I'm what you call vascular and skull base neurosurgeon. So my whole world revolves around this area and operating in this region of the brain, okay? It's very challenging because it's deep, you go underneath, you have to deal with the vessels and cranial nerves and very critical structures. So that's my, essentially, what I do. Okay. Let's discuss aneurysms for a second. And I want to explain something to you before I show you how we do it and then show you how we can innovate. So let's establish some principles. So this is okay. So imagine this is a carotid artery coming up. And it has this aneurysm on it right here. Okay. So your job is you have to get there safely, like I talked to you about, to go sylvian fissure, whatever. Then you have to place a clip across the neck of this aneurysm, closing off this aneurysm, while making sure all the blood, normal blood, is going normally into the rest of the brain. And that's a successful kind of what you want to achieve. Now, it's not just this artery that you're worried about. In reality, there are tiny, tiny vessels that come off here that are what we call perforators, okay? These vessels are as important as this vessel if you were to close off one of these vessels in your clipping. So imagine you put in your clip and you did not recognize or know, and you closed off this vessel. This vessel could be one of these perforators, for example, the anterior choroidal artery that supplies the internal capsule that controls the contralateral side of the body. That would mean the patient will have a stroke after surgery. No different than if you closed off with this clip, you closed off this vessel. So the challenge is that you have to be able to not only worry about the major vessel, but the tiny little vessels that come around the aneurysm, and make sure you don't occlude them. So this is, now I'm going to walk you through the first example in innovation. I'm going to share with you my own path in neurosurgery and my own thinking so that you may someday use a similar way of thinking about doing something. The problem is when you have a tiny vessel here and you're doing surgery and you put your clip, you're all happy, everything went well, and you did not see you close off this vessel. The patient, of course, is under general anesthesia. You have some monitoring, but you don't know that this vessel is closed off. The patient wakes up after surgery, not moving the whole other side of the body, completely paralyzed. It is too late. There is nothing. Everything looked good to you. The big vessel was open, but this was closed. And you thought you're patting yourself on the back, you're all happy and everything, and this is a problem. So this is what I confronted with as when I came out of my fellowship and I was doing vascular neurosurgery, that in our literature, in our practice, there's these patients that may have a complication, significant one, without knowing that something went wrong until the patient wakes up from surgery. So the problem with brain vessels is this. So if this is a brain vessel and you went in and by mistake you closed it off, okay, imagine that this is this artery. If you knew within next 30 to 60 seconds that you got it closed off and you remove this thing and readjust it, the patient will be fine because the brain very quickly recovers. However, if you have this vessel and you close it off by mistake, and you now finish the surgery, you do the closure, and you're in a recovery room, and hours have passed, minutes to hours have passed. If you go back in now to remove this obstruction, it's too late. The brain does not tolerate this. So if it's in seconds, if it's in hours, it's too late. Even if you remove this, it's too late. The stroke has already happened. So the problem in these surgeries, by the time the patient wakes up after surgery, it's too late. It's the patient is in recovery room. It's too late to go back. Nothing is going to change this fact of the stroke. So this is the concept that I had to face in my career in the field of neurosurgery, and understand that this is an issue that all of our vascular neurosurgeons are facing around the world. So let me take you to the pathway of what I went through to think about how I can address this problem. So I want you to think this way in the future. When I was a resident in training, I did a lot of surgeries under what we call awake or under local anesthesia. These were surgeries in neurosurgery that were being done for simple tumors in the surface of the brain or seizure operations, not these complex procedures. So I had learned that there is a way you could do awake surgery on the surface of the brain for simple lesions, which is well known for tumor or glioma surgery. I started to think, why not advance these complex operations into the awake area? What would that do? If the patient is awake and I've got this vessel closed off, I'm going to know right away. Within seconds, I'll know because the patient's being tested. And then I very quickly can remove or readjust this clip so I can recover that function. So this was the concept on which I developed my next, what I'm going to show you now is the next idea of what I started to do and where that's taken us. So essentially, I'm going to show you a case here. This is a patient that has two aneurysms on the carotid artery. One is a straightforward aneurysm. The second has this vessel I'm talking to you about right next to it, which is dangerous, okay? So let me take you through this and explain to you what I did to avoid that kind of complication or a disaster, really. So let's orient ourselves for a second. I know many of you are not, familiar with this kind of anatomy, so I'm going to show it to you. Okay. Of course, there are students who are taking my current course on this kind of thing. And those who are taking this course, this will appear very simple to them. But for most of you who are not, let me talk to you about what we got here. So this is a carotid artery. Right here. It has this aneurysm right here. And it has this second aneurysm right here. Okay. This aneurysm is straightforward. The second one has this this vessel that's coming off right here at the neck and goes around like this. This goes behind the carotid artery. And it's going to go to supply the internal capsule where the motor fibers are. This artery here, naming is not important here, but it's called the anterior corotal artery, okay? It's a tiny artery, but it supplies very important structure. If you close off this artery, the patient will be paralyzed on the left side of the body. Now, when I'm putting the clip here, of course, there's no problem. But I'm putting the clip here, if by mistake I close off this artery and I cannot see the tip of the clip or I'm not visualizing enough, I can cause a disaster. Okay, so let's see what we are going to do here and how we're going to avert this situation. So here I am. This is, of course, under the microscope. I'm putting a clip on the first aneurysm. Right there. No problem. I'm all happy. Everything is good. Okay. Now, let's come to our troublemaker, which is this artery right here. You see how I'm being very careful. I'm going to put this clip across the neck of this aneurysm. But remember, I cannot see the tip of my clip once I advance it deep inside. Can it be by mistake occluding this vessel deep inside without me knowing? Okay, so that's the whole issue. So I'm closing that clip, but in a second, you will see I'll know 100% that there is not. Okay, so we go through this. So you will see what I'm doing here is the minute I place that clip, I'm going to test the patient right away. This is a gold standard. There is no better way of knowing this. The patient is actually awake and I'm talking to her and everything is going fine. My hand. She's moving the left hand? Fine, just put her back to sleep. You see, once my clip is closed, if I was closing that little artery, she would not be able to move her hand. Okay. And once I know it's okay, we're good. I know 100% that there is not going to be a complication, 100% during surgery. Why can I do this? Well, the brain is very smart. The brain feels pain for everywhere in the body except for itself. It does not feel any pain. So for the part of surgery where we're doing the craniotomy and opening, where there's skin and bone, the patient is asleep. Once we're operating here, the patient is awake. And once we're closing the skin and bone again, the patient is asleep again. So there is no pain situation here, okay? And that's why I can do this and do it that way. So I want to teach you how to become a surgeon scientist, not just a surgeon, okay? So surgeon scientist, or in my case, a neurosurgeon scientist, is the combination I want you to become, okay? not only you have an idea, and I'll show you in a minute how I advanced that idea and how, why it happened, then you have to be able to publish your data and show in the literature. You have to learn how to do research. You have to learn how to develop a research and that kind of thing. So once I did this first awake surgeries for aneurysms, I published my first 30 consecutive cases of awake surgeries for aneurysms. And what I did is that I compared my results to large academic centers in the United States where we have thousands of patients of pooled data for around the country. What are the things people would be interested in of what was the outcome of my 30 surgeries as compared to the standard surgery done under general anesthesia? So we looked at length of stay in the hospital after surgery. It could be 8 to 9 days, 7 days, whatever. In my awake surgery, the patient only stayed 3 days after surgery. Okay, that's good. What's the other thing I want to look at? We want to see where did the patient leave from the hospital. If they went home, that's great. But what if they didn't go home? Did they go to a nursing home or a rehabilitation, meaning they had a problem? Well, it's 17%, 16% across the board, across the United States and the general anesthesia. Only 3% had to go to a rehabilitation after the awake surgery, which is good. The main thing is stroke. We've been talking about risk of stroke after surgery. What is the risk of stroke? 13%, 7 to 8%, 14%. In our awake cases, only 3%. Okay. And that's the lowest ever been reported in the field of neurosurgery. Modified Rankin scale is the functional outcome of the patient, not available in the large data banks, but 1 meaning went back to normal life after surgery. Of course, then the death rate is about 2%, 2.5%. Luckily, we have had 0 mortality in these surgeries that we have done. So you have to not only do the idea, but you have to prove it to that it works, and so you have to become a scientist, not just somebody who has great ideas. That alone is not going to work, folks. Okay, so this is what I'm trying to teach you. Now I'm going to take you very briefly through the idea of is the idea of how did I came up with an idea. How do I take it stepwise into making it happen? So as a surgeon, when you have new ideas, you cannot just start working on start operating on a patient. That would be unethical. Okay, so you have to develop a process, and you have to meet the board, a board of institution review board. You have to explain to them why this idea would be better than doing it the standard way under general anesthesia. So they, of course, will require you to a number of things. So when we started doing this study, these are the things we had to do. I, as a surgeon, had to meet with the patient or in the family in the outpatient clinic and discuss this option of doing it awake. Then I or the surgeon will meet with the patient and the family the day of surgery and discuss the option of awake. Then the anesthesiologist meets separately with the patient and family to discuss the same thing. And then the resident, and so 4 different steps that had to be done. When would the awake surgery not be done? If the patient declines the option, or if the anesthesiologist says, listen, the airway, I'm not comfortable, if we have to do an emergency intubation, this will not be safe, then no way the awake will not be done, will be done under general anesthesia. Okay. So the protocol was approved for complex aneurysms and vascular malformation. The reason is simple aneurysms and AVMs, they felt that already has reasonably good outcomes, so that would not be the place to prove it. But complex aneurysms and vascular malformations have, in general, relatively high bad outcomes in them. So this would be a good place to look at this first before we allow it for all of them. So this is how the protocol was established. Okay, so this was this protocol that ran from 2013 to 2019. Okay, so let me share this data through the board just came out, and I was given this data, and I want to share it with you. Okay, So they looked at all my patients during this time period. I did 202 craniotomies for complex aneurysms and AVMs. This does not include the simple lesions, the simple aneurysms. Of this 202, 162 patients underwent awake, and 40 patients underwent general anesthesia because they declined the option. So I'm going to show you both right now, and then I'm going to show you the outcomes in more detailed way. So this is how these committees look at your data through electronic health record. They look at every variable. This is redacted because it's personal information of the patient, morbidity, mortality, everything about the patient they can look at, okay? And then they looked at the 40 patients who underwent general anesthesia, standard surgery for these complex lesions. So what did they find? In this 202 craniotomies for complex aneurysms, vascular malformations that I did, we went from a risk of morbidity, meaning complications, from 10% in the general anesthesia patients to 4.3% in the awake patients. We went from death rate of 2.5% to 1.8% in the awake patients. Combined is this here. So essentially halved the risk. So essentially, I guess what I'm gonna try to tell you, and let me put modesty aside for 1 second, because you may not be aware of outcomes in the field of neurosurgery. These outcomes in awake here for complex aneurysms and AVMs are the best ever reported in the history of neurosurgery, okay? So this innovation, this thinking led to a major change in outcome. So this is what I'm trying to share with you, the idea how you develop yourself, how do you do things to improve outcomes and even, you know, avoid death in patients by changing things. So this is what I'm sharing with you today as an idea for you to think about it, these things, okay? So next, I want to talk to you about something a bit more general. Essentially is the most dreaded complication during aneurysm surgery. While you're, like I showed you, I was doing surgery on a patient. If the aneurysm ruptures during surgery, this could be a disaster. It could be a massive stroke or even death. It is a really bad complication, okay? So let me share with you an experience I had with this and tell you how I think as a surgeon during when something like that happens. Okay, so I will show you in a minute the way we teach you about neurosurgery. It's a very 21st century way, and we're going to show you in a minute a university program that I have to teach medical students. We're going to teach you in a very way that you can really understand, and it does not sound complex. Anyway, so here's a patient. Let's look at this, what's called an angiogram, which is looking at the blood vessels of the brain. This is a frontal view, so this will be the right eye, the left eye, we're looking at the front, and the nose would be here. So what we're looking at here is internal carotid artery coming in, divides into the middle cerebral artery and the anterior cerebral artery. Here we have an aneurysm, okay, that the patient had. This patient is a young guy in his 20s, okay, just recently married. Luckily, when he had the bleed from this aneurysm, it's a low-grade bleed, which means he was awake and alert, just had a bad headache, luckily. It could have been worse. So in this patient, he went to the local hospital in his state in the United States, and they did what's called endovascular treatment. They put a catheter up the internal carotid artery and went to the aneurysm and tried to put coils inside this aneurysm. The neck was too wide and the coils kept coming out. So they aborted the procedure. They stopped. And they called the neurosurgeon, who is an excellent neurosurgeon in their hospital, to do an open clipping surgery like I showed you. Now, this is where it gets interesting. This patient is in rock and roll band, okay? And he's a guitarist. So the neurosurgeon went and talks to him, and the patient asked him, what is the risk to my function in potentially this surgery? Well, the neurosurgeon honestly tells him there are these tiny vessels like the ones I showed you before around this aneurysm, that if they by mistake get occluded in the clipping, these vessels control your arm and leg movement. Not even that, they even control your personality and memory. The guy said, stop, I'm not having any surgery. I'm a rock and roll guy. I don't want to. The neurosurgeon tells him, listen, if this aneurysm bleeds again, you will die from it. So it's not like, and the risk of bleeding is the highest in the first 24 hours. The guy says, no, I'm not having surgery. So this was a dilemma for this neurosurgeon. As luck would have it, some 3 months before this patient showed up at this hospital, I gave my presentation at a major Congress meeting of my first experience doing these awake surgeries and showed my data. So this neurosurgeon happened to be in the audience that day. So 3 months later, he's facing this situation. He gives me a call. He said, listen, I've got this problem. This guy is refusing to have surgery. I've talked to him about you, and he's willing to come to you. I said, listen, if the patient ruptures in the plane ride, it's like a 3-4 hour plane ride, he will die. The neurosurgeon said, listen, what difference does it make? If he ruptures again sitting here, he's going to die anyway. I said, okay, fine, send him. So the patient shows up, very nice family, recently married, his parents, and I had a really detailed conversation with them. You know, they showed up around, 18, 19 hours after this situation. So it was late in the afternoon, early evening. I didn't want to wait until the next day. I decided to do the surgery that evening, okay? Because we're already I'm worried about him rebleeding from his aneurysm. So the guy says to me, listen, can you make a deal with me? I said, okay, what's the deal? He said, listen, I understand the neurosurgeon explained to me exactly how you do this. How do you put the clips and you check for these tiny vessels and you check my arm and leg function and stuff. But with me, I want you to do something. I want you to test my guitar skills once you have the clips on this thing, okay? I want you to test my guitar skills once, because if there is a problem, then you can readjust the clip. And I understand that's what you do. I said, okay, in your case, I'm willing to do this, but I'm not guaranteeing anything because no 100% guarantee in this kind of work we do. He said, fine, I understand. So we decided to proceed. Now remember, so what we do is what's called a craniotomy. We remove the bone and then we open the covering of the dura. As soon as the opening of the dura happened, I suddenly saw a gush of arterial blood like crazy coming out. I knew right away the aneurysm had decided to bleed on us the second time, right at this moment in life. I wish it had waited until I got to the aneurysm, but it didn't. The blood was coming out. Immediately I took over and I went through the sylvian fissure very quickly to get to the aneurysm. Next, I'm going to show you what I saw and how the aneurysm is bleeding, live right here. Okay, so this is the angiogram. That's a 3D reconstruction of the aneurysm. You see, the aneurysm is bleeding live. What I'm going to show you, very few neurosurgeons have ever seen in their lifetime, which is an actual hole in the aneurysm where the aneurysm is bleeding. I put what's called temporary clips. And you see, right now, you will see the hole right there, the actual hole from which the aneurysm is bleeding. Now, remember, this patient is awake, okay? We had not known this is going to happen, of course. So this is a very rare kind of situation ever to happen. So everybody's calm and quiet and everything is cool and nobody, is, because of course we have to be like awake. So I'm stopping the bleeding from the aneurysm. I was very lucky to be able to stop it right away. So I was very happy that I was able to do this right here. Just stop the aneurysm from bleeding, okay? Once that happened, now I'm feeling a lot better because this could have been a complete disaster, okay? Because it can be really a big problem once this happens. So now I've stopped the bleeding. Now I'm putting the clips across the aneurysm. It needs 2 clips because there's a little baby part of the aneurysm right here, and that's a normal vessel behind me right there, okay? So I'm gonna put the second clip just getting this, the whole aneurysm is closed off now, okay? Now, I'm removing what's called temporary clips. This is a right optic nerve, left optic nerve. You see, I'm testing all these tiny vessels around my clip, make sure they're all open. This, as I promised him, is testing everything I'm doing here, because I'm talking to him, I'm testing his memory, his function, his guitar, everything is going just fine. Okay, so I'm very happy now, okay? So this was, there's no way under general anesthesia I would have known that. I would only know that after surgery and it would be too late, okay? So that is really the things that I'm showing you here. Okay. This is a small procedure we do during surgery. Anyway, 1 week later after.
Dr. Ray, I'm a better guitarist and singer since that surgery. Thank you.
I had him say for fun that his guitar skills improved because I operated on his brain. Of course, all for fun. Anyway, he went back home and, you know, back to his part of the country. And then he came back a year and a half later to see me. And he had a little nice surprise for me. And I'll show you that surprise right now. That's his little son who was born in the interim right there. So, you know, all the great things that we do, accolades, diplomas, awards, recognition is all fine. But at the end of the day, this is all it's about, is saving function and saving life. You know, you guys all will get all these great things and recognition, but don't ever forget why you do what you do. It's for this reason. That's why we are here, okay? And don't ever lose track of this fact, because you need to stay grounded, stay grounded. The more you do and the bigger things you do, it's more important that you stay very grounded. So I talked to you about the first concept of innovation. The second idea I want to talk to you about is the idea of thinking outside the box. That's a very important idea that you have to really develop and start thinking to be somebody who impacts your field. Thinking outside the box is very important. For me, this was important because I have, you know, worked with athletes. I mean, much of my life has been revolved around sports since I was a little kid. So, for example, I learned from sports people. You see, this is, for example, a big convention of owners and coaches of major professional teams in the United States. And they learn from each other about how to deal with failure and how to lead, but you also invite people like me and other people, like in this year, it was me and an astronaut from NASA to share with them how we do things. So learning from other people outside of medicine and how they handle things is very important. And I have learned a lot of amazing lessons from this phenomena. So I wanted to share that with you to make sure that you also utilize that. Let's see how much time we have. Started. Yeah, probably don't. Okay, maybe later if we have time, I will show you this example. But perhaps we should. So, for example, Carlo Ancelotti, who's the head coach of Real Madrid, and I have talked to groups of people, of leaders, about how to think, how to develop teams, how to evolve, you know, thinking in developing the teams for success in the long way. For example, I'm very proud of the teams I've developed in the United States. to really to be successful. Okay. The second thing I want to talk to you about, the second procedure or second example of innovation, is a procedure that has been the part of neurosurgery that I have loved the most, of vascular neurosurgery, which is taking a vessel from outside the head and attaching it inside the brain to bring in more blood flow to the brain. Okay, and this is called extracranial to intracranial bypass surgery. Okay, this has been an area I probably have contributed to more in neurosurgery than anything else. Okay, so this is bringing blood flow from outside inside to do that. Okay, so let's talk about this for a second. So in this example, I'm going to again show you. So the aneurysm we showed you so far, the two aneurysms were probably this big. So if you put a clip or you put coils in these aneurysms, the blood flow is going fine to the brain, it's fine, whatever, no problem. But when you have an aneurysm this big, okay, if you start putting clips on this aneurysm or start putting coils in this aneurysm, these clips or coils will push towards the carotid artery. It'll close off the carotid artery. There'll be no blood going to the brain. You could have a massive stroke or death as a result of that. So this is straightforward clipping is not going to work here. So for this, you have to do what's called high flow bypass. Okay. And what that entails, imagine this is the hand of the person. I'm not very good at drawing, so let's just do this here, okay? Okay. You harvest the radial artery, just like they do in heart surgery. And this is what you're gonna have to do. We're gonna have to attach that radial artery down here in the carotid, then attach it here. So the blood will go this way, this way, this way, then it'll go this way and this way. Okay. You have bypassed the aneurysm. Now you go in and completely close off the carotid artery in the whole aneurysm. So this is called high flow IC bypass surgery. Okay. Of course, this is only done in hands of very few people who are highly experienced. You know, it's a complex procedure. You know, to do this kind of work. Okay. Now, let's explain how this is actually done. So imagine this is the head of the patient. This is their neck area. So essentially, you have to you of course made the incision on the arm to get the radial artery. You have a long incision in the neck, and you have this long incision in the craniotomy in the head. Okay. And then essentially you take that radial artery and you attach it to the carotid in the neck, then you tunnel it underneath the skin in front of the ear, you bring it inside the craniotomy and attach it right there to the artery. So the blood will go this way and then you can close off this thing. Okay. This procedure, this high flow ECIC bypass, had been pioneered by the generation before me. There were a few neurosurgeons who were doing this procedure with this kind of thing, long incision in the arm, neck, and this. So when I came into it after doing my fellowship at Yale, and I was very interested in bypass surgery, I started thinking, this is such a big procedure. How can I make it less invasive and less risky? This is my second example of innovation for you, so you understand how you have to think in the future for yourself. Okay. So I'm looking at this whole thing. I'm saying, wow, I started doing these, and big procedure, very intensive. I mean, there's only a few neurosurgeons in most countries who do this anyway. So it's a very complex thing. And I started thinking, what can I do to make this procedure not so big, not so invasive, okay? So that's the second example I'm gonna show you today as to what I was thinking and what I was gonna do about it. So first, let me show you this standard procedure first. So essentially, you bring the radial artery, and this is inside the brain where you're attaching it. Let me first show you attaching it in the neck. So this is in the neck. That's a radial artery you just harvested. You're attaching it to carotid artery in the neck, okay? Right there. And you're doing a nice attachment. And then you're attaching it, the artery, to the artery in the brain, to the radial artery. Let me show you a minute example of innovation right here. When I came into this specialty, there were no good instruments to operate deep in the brain to attach these vessels to each other, okay? So I worked on developing these instruments with various angles to be able to operate deep in the brain, okay? And this is so these instruments in the field of neurosurgery are called the Abdul Scanlon instrument. Just a small example of some of the things you can do to improve things. Anyway, so that's attaching both of them. And then you have this long graft going, you know, from the neck to the brain to supply the brain with blood. And then you can, close off the main artery, okay? So let me talk to you about another thing. The longer this graft is, in the physics of vascular surgery in general, anywhere in the body, the longer the graft, the higher risk you're taking of some thrombosis of the graft. The shorter the graft, the higher the success rate of the graft. So these were ideas in my head when I was starting to think what to do, okay? So what I started to think is this. So if this is a patient's head, okay? This is a neck, the neck of the patient. What if there was a way for me to take that a shorter graft like this, somewhere here, closer, and then attach it instead of going all the way from here to there, okay? This is the idea I was doing in my head, okay? So I want to show you what I came up with and what this idea is. So what I decided to do is this, I decided that there's an artery that, because I'm a skull-based surgeon and I operate at the base of the skull, if this is the head here, okay, the base of the skull is here, the brain is all here. Underneath the base of the skull, there's an artery that's a branch of the external carotid artery that comes here right there. It's called the internal maxillary artery. So I decided that instead of going all the way from here to there, that I'm gonna go from here to there to do this surgery, okay? To make the operation, to make no long incision in the neck, only a short incision on the arm, and of course a shorter graft, which is better for success, okay? So that's what I decided to work with, and I started doing my whole, I did in the lab, I did many things. So this is a difference. If you look from the top of the head, where the surgeon is, in this standard procedure, if this is a big aneurysm sitting on the carotid artery, in the standard procedure, you go all the way from the neck, the radial artery is attached to it, then is attached here. The blood will go this way and this way to the rest of the brain. You can go on and close off the whole carotid artery. I decided, instead of that, I'm gonna find the maxillary artery underneath the base of the skull, bring it through, then I'll attach it from there to here. Now the blood will go this way and this way. And because the maxillary artery is a branch of the external carotid artery, I can go on and close off the whole internal carotid artery, because the blood will go this way, this way, this way, and there. Okay, so I'm bypassing the aneurysm with a smaller procedure. So that is the procedure that I described. Okay, and this is a procedure that is no, I mean, one of the senior neurosurgeons from the generation before me, not me, named this procedure the Abdul bypass procedure, and I was very humbled by that in the field of neurosurgery. And actually, those neurosurgeons who do these procedures now, again, you know, they are calling the IMAX the Abdul artery because of this procedure. I'm totally humbled by this. It is really humbling for me in my field for that to happen, but it is those things in life. Okay. And as Sneha spoke in the beginning, you know, I've written the main textbook for brain bypass surgery. And I'm very proud of this fact, of course, and it's an area that I have feel like I've contributed to quite a bit. Next, as we are coming to a finish, I want to talk to you about something that has been really perplexing me in this stage of my career and what I want to do about it. Okay. So I want to talk to you about the issue that is a problem in using a Nobel Prize winning work called the Dunning-Kruger Effect. Okay. And I'm going to talk to you about confidence in oneself as opposed to number of years in practicing that specialty. So imagine there's somebody, a resident in neurosurgery, spent 6-7 years training, and they just came out of training. Okay. After working that hard in training that kind of specialty, he or she feels like they're in the top of the world. They're the best there is. All of us been through this, by the way. Okay, this is not a unique thing. All right, and they are the best, and so forth. And that's in confidence. What happens in the next few years is this: the confidence starts coming down, like this. Why is this happening? Because they start having complications. They start having problems. And suddenly they're at the bottom here and really feeling down about themselves. And then those who are driven, who start doing series, who start doing research, who start publishing, get here. This is being a master. Master is never here. This is not realistic. Okay, 100% is not. This is a master. Okay. In my opinion, every neurosurgeon needs to be a master. It's a specialty with high risk of function and life. So there's no option but to be a master. Okay. The problem is this. This journey here takes about 30 to 40 years. In average, not for every, in average. Meaning, by the time you get here, you are in your 50s or 60s. Okay? That is a big problem. That means we lost so much in the process. That means, first of all these poor patients got hurt. That means your research potential of what you could have contributed to the specialty, we have lost. That means you have lived a very difficult life, miserable. A lot of people become miserable and angry and so forth. So, of course, this is a problem. So I saw this problem, and I saw that my goal is to push this curve to the left. Now you say, why? How can you push to the left? Because I have observed the exception of this curve. I have observed this. People, I know a number of people, including myself, who were very lucky. I was very lucky because I had amazing mentors, and we're able to get here in their 30s. So I know it's possible. and I know it is reproducible. So I have now envisioned myself, what I'm doing around the world is helping young people, even people who are already neurosurgeons who are here, and residents, and of course, medical students, to start this journey like this, not like that. So my goal is to start your journey in this specialty in a different way, okay? This has been the dream for me for many years, to do this impact and how to do it. I know the formula for it, so that's how I got here. So I'm going to show you what I developed.
Meet the Abdul University of Neurosurgery, the first online academic degree in neurosurgery worldwide. This online nonprofit US-based university offers students, residents, and fully trained neurosurgeons around the globe a range of modules, elective classes, and research opportunities to develop their knowledge in neurosurgery. Developed and established in 2021 by over 90 administrators from 24 different countries, our online degree welcomes any keen students and doctors, and includes a bachelor's, a master's, and doctorate degrees. Our courses have been developed in a flexible format to suit a variety of learning styles and to support students who join from all corners of the globe, focusing on their success. Without being tied to a physical university, learn from wherever you want with the support of experienced mentors and expert guidance. We offer very affordable tuition and a scholarship program to support our keen students. Its state-of-the-art online learning platform and website, developed with a minimalist design, brings the most efficient workspace, accessed from anywhere you want. Neurosurgery is changing. Be part of the change. Apply today.
The main requirement for medical students who enter this is that they have to do a research project with us that is published. So that is one of the main things that we require from people. Any of you who want to look it up, you can look it up. This is based in the United States, but available globally for this next generation of neurosurgeons. So that's something I wanted to share with you. The other thing I want to share with you, as I'm talking to students all over the world, if you go down your path in life like I just showed you, then you could also live your life. The problem is I had mentors who are always bad mood, they're upset, they're surgeons who are always tough to deal with. It doesn't have to be that way. So if you move in your path and you're doing well and you can achieve your goals, then you can live your life as well. And it's very important for you people who want to go into surgery that you have a balance in your life between your work and what you want to do with yourself, because then you will become a better surgeon versus if you are a miserable human being always in bad mood. So I love wild animals. This is a wild elephant in Nepal that I became friends with. Okay, baby boy Thor. You guys have met baby boy Tank, my dog. We like to race cars. I love animals. I've been in sports. I love racing cars. So I could do these things because I was able to be lucky enough to be in that part of the curve, is to achieve that earlier. So my recommendation to you is seek your career in surgery so that you could achieve your goals earlier and you can live your life and to the maximal potential. I think that's a very important message to send to those people who are thinking about going into surgery. Now, I'm the global president of the D&D Society, and we have clubs for medical students all over the world. The D&D Society works in collaboration with the University of Neurosurgery, and we have clubs in many countries around the world. Our clubs are very active. We just had our World Congress meeting for our clubs just 2 weeks ago in Crete, Greece. And the clubs, the students have become so close to each other. They're closer friends with each other across countries now with their own friends in their own country. That's how close of collaboration these students have developed. So if there are students on this lecture who are from countries that are not represented here, I think you should really contact us and develop a club for your country. I'm, you know, especially we are really focused. We really want to develop clubs in, you know, of course, the North, South America, and Europe are the biggest hubs right now. But we want to see countries in Asia and in Africa to come on board for sure. We'd love to have you with us as to be part of this journey with us. Okay. We just had our first World Congress meeting for medical students entering the field of neurosurgery. And Mariana, our medical student from Greece, just sent me this video. I'm going to share it with you real quick. So this was the organizing committee that put this meeting together. And I want to acknowledge, I mean, you know, this is an amazing group of students from all over the world who put this meeting together, okay? So we have students from Germany, Romania, Greece, you know, this was in Europe, so it was mostly Europeans from all over Europe. All of these are our officers of our clubs. And I hope to see many of you to join this team as we meet together in future events. Those of you who want to apply to develop a club in your country, you can contact either Michaela, our officer in Germany, or Soleil, our officer in Lebanon, to develop a new club. We welcome you with us for sure. Or you can contact me. I'm you know, on Instagram. You're welcome to contact me for any questions, advice you have in your career. I'm happy to do that. I wish you all the best of luck in your future. And I congratulate the you know, the Global Surgical Group for this Congress, this conference, very successful, for the amazing work they have put into it. Thank you.
Thank you so much, sir. That was an amazing session. And I think like none of us have attended anything like it before. And thank you so much.
Thank you, Sneha. Thank you. Thank you so much.
Your words to think as a neuroscientist and not a neurosurgeon, and to be more considerate towards our patients and think laterally, not just in a very straight way, to, you know, to cater best to our patients or anybody in need, and learn from people around us or peers. I think those are lessons, I think, which are very necessary in the recent times and are going to stick with all of us for a lifetime. So
thank you, Sneha. That is so important. You know, I always teach my people, my fellows, residents, and students, there are things bigger than you. The problem with people, when they achieve, they think they're the biggest thing there is. And that is the biggest thing I'm trying to avoid as I'm mentoring a whole generation around the world. You cannot, okay, it's important, you will be happy and everything, but there are things that are bigger than you. And what's bigger than you is a patient on the table when you walk into the operating room. So I want people to have a great life, but don't ever forget what this is about and stay grounded. So you gotta balance your successes and amazing things you did, at the same time to keep a level of humility about it so that you could be better. So that's a key message that Sneha, you just talked about, that I'm really trying to send to students and residents and neurosurgeons all over the world.
thank you so much, sir. And I don't think there was anybody better who could deliver this so well and elegantly rather than you.
Thank you. I'm humbled by you saying that.
Thank you, sir. So with this, I would like to end the session. Thank you so much, sir, for joining us today. And I would like to thank all the delegates to join us, for joining us today on the YouTube Live as well. And please stay tuned for tomorrow's events too. Thank you so much, sir. Thank you. Bye-bye.